to look at how prevalent it still is right now and how it's been affecting our fellow residents and hospitals and how there's a new vaccine out there to fight it as well. And we're always very appreciative and lucky to be joined again by Dr. Joseph Blondeau. He's head of microbiology at Saskatoon's Royal University Hospital. He also teaches about infectious diseases at the University of Saskatchewan. Now, one thing to remember, Dr. Blondeau is not part of policy decisions made by the government. So keep that in mind if you have any questions. But we'd love to get your other questions on about COVID-19 in general, the Omicron variant. We're going to talk a bit about a subvariant, the latest vaccine approved by Health Canada, and anything else. You can give us a call right now, 1-800-716-2221. Now, if you prefer to email, just a note that last time Dr. Blondeau was on the show, we had a lot of emails late in the show, and it's very hard to get those emails on if they come in late because we often get many callers as well. So get those emails in right away. bluesky@cbc.ca, or you can tweet me. I'm at TweeterMillsCBC, and I'll pass your questions along as well. Already seeing some coming in on Twitter. We're also live streaming today's show on the CBC Saskatchewan Facebook page, so you can ask your questions in the comments section there, and we'll try our best to get some of those on. And again, the number to call right now, 1-800-716-2221. And with that, we're once again very grateful to have Dr. Blondeau back with us. Hello, Doctor.
Peter, how are you?
I'm doing well, and that's the way I always like to start this because it has been a while since we talked. How are you these days? Are you enjoying winter or just counting down the seconds to spring?
I am counting down the seconds, and I'd like to do it in leaps and bounds. I'm tired of winter now, and I would like to see the warmer weather come in for sure.
Great. Well, as you know, the Saskatchewan government providing less information these days, weekly now. So what do we know about just the current COVID-19 situation in our province?
It's hard to have firm numbers in regards to the activity within the province because, as we know, there are a number of people who are testing by home rapid antigen tests, and that the number of people that are currently eligible to have, say, a hospital-based PCR test, that number has been restricted over the last little bit, such that it's more high-risk groups, those in long-term care, congregate living, healthcare workers, outbreak situations, etc. And so it's hard to know exactly what our numbers are looking like without having, the numbers that we had back a while ago. But what we do know in this country is that it would appear, at least from this current Omicron surge, that it has peaked in a number of areas. Some other areas probably are still left to peak. We know that hospitalizations have gone up, and that was predicted and expected from models. And we also know that the corresponding percentage of patients that required hospitalization that did not require admission to the intensive care unit and, say, critical care support, including, mechanical ventilation, those numbers have not paralleled the numbers of individuals that have been hospitalized. So in other words, if you expect a certain percentage of hospitalized individuals to go into the intensive care unit, when you look at the number of people that were infected and hospitalized in this wave, we didn't see the same percentage of individuals requiring ICU admission that we'd seen with some of the earlier variants. So that's good news. It means that the data indicating that, for many people, this is a milder infection. And we can't discount the importance of vaccination. And to that point, Peter, we do have some new data now that I think is well worth commenting on. And this is data that's summarized not only by the Canadian government, but also other governments around the world. And it's available to anybody who wants to sort of just Google it and look it up online. And now we divide data into unvaccinated and vaccinated, those not yet fully protected, those only partially vaccinated, those fully vaccinated, and those fully vaccinated and with a booster dose. And in that data set, not only from Canada, but other countries, the data is quite revealing. And I'll just share a little bit with you. So if you look at the number of cases that are recorded in this country, and this is data that's summarized up to the end of January, so January 30th of 2022, about 60% of cases were occurring in unvaccinated individuals, and about 35% of cases were occurring in vaccinated individuals. If you further break that down, cases not yet protected were about 3%. Those that were partially vaccinated around 5%. But where the big difference came, Peter, was if you compared those fully vaccinated and those fully vaccinated with a booster dose, the numbers were dramatically different. So while 35% of cases occurred in people that were fully vaccinated, only 6% occurred in patients who were fully vaccinated and with a booster dose. So now if you look at that same data now based on hospitalizations, again, very dramatic. I won't go through every single data again, but suffice it to say that the number of people requiring hospitalization that were fully vaccinated was approximately 17.5%. Yet if you were fully vaccinated and with a booster shot, that number would drop to 5%. And then in terms of deaths, once again, a similar dramatic difference. Deaths in people that were fully vaccinated accounted for about 15%. Yet if you were fully vaccinated with a booster, that number was 6.5%. So clearly being vaccinated and then having the additional booster doses goes a long way to protecting you from hospitalization and from death. I would be remiss if I didn't report that, among those that were hospitalized and died, the vast majority of those individuals, sadly, were unvaccinated. So the number of hospitalizations in the unvaccinated population was 67%, and the number of deaths, 66% in unvaccinated individuals. So the vaccine program works, and being vaccinated and being boosted protects you from hospitalization and from death. But it's not 100%. And we're waiting to see a further breakdown of the data on whether or not these more severe infections and death in vaccinated people and those who are vaccinated and boosted are occurring in vulnerable populations, i.e. those that are more elderly or those with underlying medical conditions. I don't have that data yet. But data from other regions of the world suggests that that's the trend that we might expect in Canada. So I think that this data, Peter, is very, very important, and I would encourage everybody to just go onto the Government of Canada website and just look at it, because it's based on millions and millions of data points, and so it's not based on a small number. It's based on the population of the country, and for that reason, I think it tells a very intriguing story.
Great. All right, folks, if you're just tuning in, our guest is Dr. Joseph Blondeau, head of microbiology at Saskatoon's Royal University Hospital. And if you have a question for the doctor, give us a call right now, 1-800-716-2221. Already seeing some emails coming in. That is fantastic. Again, might be your last reminder because we often get quite a few, and it's hard to get them on if they come in late in the show. So email right now, bluesky@cbc.ca, or you can tweet me at TweeterMillsCBC. Let's start with the phone lines. James is in Saskatoon. Hello, James.
Hello, Peter and Dr. Blondeau. My question is that I've noticed that this virus ebbs and flows seasonally. And we're going from a very cold winter to hopefully a warm spring. And there'll be a lot more activity. So if we allow our infection rate to grow from, as it is, because the more we open things up, the more it will spread, even if people do not become seriously affected by it, they still have it, and it still has a chance to mutate. What should we be doing to kind of stabilize things so that we don't get another wave when the weather changes?
Yeah, so a really good series of questions there. There was more questions in there than just one, and I'll try to address this. So we haven't talked a lot and heard a lot over the last 2 years about other seasonal viruses. These are viruses that cause the common cold and or influenza, which we know can be a severe disease leading to death. And these are infections that occur on a seasonal basis. So, the respiratory season can go anywhere from October to April. It varies depending on when virus is introduced into the community. And there is chatter that's out there now in the literature and some expert opinion opinion that's actually suggesting that we may start to see a similar trend with COVID-19, meaning that as we're coming into the summer months, there's at least one editorial in the journal Lancet, which, if you're familiar with the printed literature, it's probably either the first or second top journal in the world, where some modeling data suggests that we actually could see a period of quiescence over the summer months as we start to transition from winter into summer, and that we may see a resurgence in the fall. Now, of course, these are predictions based on models, and we don't know this 100%. And I think that it's also realistic to expect that, with restrictions being eased across this country, we may actually see a flare-up of some cases that kick in after some of the restrictions are lifted. But unless a new variant arises that we don't yet have any knowledge of, it is quite possible that this virus will transition to a seasonal virus, and it may never go away, and we may see it on an annual basis. And whether or not it will contribute to the necessity of having it as part of our annual immunization campaign, I think those discussions remain to be completed. But that's our current status, and Peter will tell you, because we've said this before. We've been fooled. One day we thought one thing, and then some new data come out, or something happened, and the next day we had to change our opinions. But at this point in time, that is what some of the conventional thinking is. Although the World Health Organization is suggesting we could have another variant that will arise, and that's always possible when the virus continues to circulate. But there's no way of predicting when or if it will be, and how serious or how less serious that variant will be.
Thanks, James. Appreciate you calling. Again, folks, if you're just tuning in, you can give us a call with your questions right now, 1-800-716-2221. Dr. Blondeau, I have this email from Kathy who asks, could you explain why some places want people coming into them to replace their N95 masks with surgical masks? Of course, we don't know exactly which places Kathy's talking about, but just from my own experience, I know, I've gone into a doctor's office or once the hospital in the past 2 years, and of course they give you one of their own masks. Can you explain just the difference between N95s and surgical masks?
Well, an N95 mask is the best mask that we currently have available, and it's called an N95 because the data would indicate that it's effective at removing 95% of the particles that you may be exposed to. Surgical masks offer less protection, but certainly a lot better than no protection at all. And the reason why somebody may ask you to change your mask is they have no idea how long you've been wearing it. They have no idea whether it's a new mask, whether it's an old mask. I do know that I have been asked whether or not the mask I'm on is a new mask, and if I want to replace it. When I come into the hospital every morning, I'm asked whether I have a new mask on or not. And so the reason is simply that they don't know whether or not you're wearing a mask which is no longer effective, and therefore want you to put on a new mask. And that's really the reason behind it.
Great. Thanks, Kathy, for sending that email in. Here's another email from David who says, a few weeks ago when I received my COVID-19 booster shot, I was given a rapid response COVID-19 antigen test kit, which I think many people have experienced. Do these at-home test kits test for the latest Omicron subvariant of COVID-19?
Yes, because it's an antigen test. It's not a nucleic acid test. The concern with the new subvariant is that one of the genes that are in the current PCR assays may not flag positive, and that's why it's been called the stealth variant because of this. But my understanding is, and I'll stand corrected if somebody has additional information, is that the antigen test should work well.
Great. I'm glad that David brought that up. I just wanted to ask you, is there anything else we know about this subvariant or anything else we need to know?
Well, there's a bunch of conflicting opinions. Apparently, there's a preprint that's circulating saying that it could be a little bit more dangerous than was previously thought, but yet there are other recognized groups that are disputing this. So the CDC, for example, is continuing to say that the B2 variant is no worse than the current Omicron variant. It does appear to be more transmissible, but they're saying it doesn't appear to cause more severe disease. More transmissibility means that it's likely then to move through the susceptible population quicker. The one contrary to this is in Denmark, where they seem to be having some problems with this particular variant for reasons that are not fully understood. But other jurisdictions around the world are saying that it doesn't cause more severe disease than the current Omicron variant. What I would say to that, Peter, though, is that, Omicron came up in December. And, for most of us here in this country, and so we went through this wave in December and January, and now we've got this subvariant. And I think that it may just be a little bit early to fully appreciate everything with this new subvariant and what its implications are going to be. But we do know it tends to be more transmissible. And we do know, based on the data that's been collected, immunization, including a booster shot, still keeps people out of the hospital and out of the intensive care unit.
All right, Marvin and James, stand by. I'll get to your calls in just a minute. We're going to have a quick news break in just about 2 minutes here, so I want to get another quick question on for the doctor before that. Doctor, well, first, Rob comments on Twitter, says, sure wish the government would have kept the mask mandate until the COVID-19 vaccination was available for all children. And then for you, Dr. Blondeau, the question from Rob is there any information on a COVID vaccine for children under 3?
Haven't seen any latest update on that data. It is expected to come, but I have not seen it yet. And if it's shared in a public domain, I can't find it, which means that it's probably just circulating amongst regulatory agencies or those specialty groups that review this type of data, and not yet available to the general public.
Great, thank you. And Rob, thanks for tweeting in. Appreciate that. All right, folks, our guest today again is Dr. Joseph Blondeau, head of microbiology at Saskatoon's Royal University Hospital. If you have a question, give us a call right now, 1-800-716-2221. You can also tweet me at TweeterMillsCBC. And if you're by your computer or your phone or whatever, I guess you don't need a computer anymore. You can just open up your smartphone. We are live streaming today's show on the CBC Saskatchewan and CBC Saskatoon Facebook pages, so you can get a question in the comments section there, and we'll do our best to get it on. Again, your questions for Dr. Blondeau, call 1-800-716-2221. Marvin, James, Verda, stand by. We'll come to those calls right away, but right now we're just about at 12:30, and Tori Gillis is back with a news update for us.
Hey there, Peter. Well, coming up in your news, Saskatoon will not hire security guards to make sure people are wearing their masks on buses. That was one option on the table for a city committee today. The majority of councillors there voted to keep the status quo after the end of provincial masking mandates on February 28th. So people in Saskatoon will be required to wear masks on the bus, but drivers will not enforce passengers to wear them. We'll have more details on that coming up. And starting today, anyone with an SGI driver's license or photo ID can choose to leave the sex field on it blank. That comes in response to a Saskatchewan Human Rights Commission complaint settlement agreement. So in addition to the M, F, or X indicator options, you can also leave it blank. SGI says anyone can make that change to their ID for free at any license issuer, and no documentation will be required. We'll have more details on those stories and more coming up in your news.
Thanks very much, Tori.
Thanks, Peter.
That's CBC's Tori Gillis, and she'll have that full newscast coming up at 1 o'clock here on CBC Radio 1. All right, again, folks, our guest is Dr. Joseph Blondeau, and let's get right to the phone lines. Marvin is in Carrot River. Hi, Marvin.
Hello. Just have a question. I saw on the news that the University of British Columbia had developed a mask or something you put on a mask that would kill the virus when it landed on the mask. Is there any validity to that, or what is the status of that at this time?
I'm sorry, I cannot answer that. I have not looked at that data nor reviewed it, but I will, and I will come back with whatever information I can find. I'm just making a note for myself.
Marvin, any other questions?
Well, a weather-related question, but I don't think that.
We'll have to get Fiona Odlum on this week or something for you. Thanks, Marvin.
Stay warm.
Yeah, you bet. Stay warm. Let's go to a different James in Saskatoon. Hi, James.
Hey, Dr. Blondeau, my question to you today, actually I'm going to have two possibly, but my first one is, how long does it take in nature for a virus to create a subset or a variation?
Oh, it can occur quite quickly. So I'll use an example of bacteria because that's research that we've been doing here at University Hospital for years and are well known for around the world. We know that in a bacterial population where you have 10 million or more bacterial organisms, you might say 10 million, that's an awful lot. It's actually not a lot. In terms of a human infection. We know that spontaneous mutants may arise within that population after it crosses over that 10 million mark, and after it crosses over 100 million mark, they become more frequent. A lot of these mutants may be mutants that are unable to survive because they've mutated in a critical process necessary for growth, whereas others may evolve to be resistant to antibiotics. And so the reason why we're not all running around with mutants is because the body clears these things, and so they may occur much more often than we think. The same is true with viruses. As a number of copies of the virus increases, mutations occur all the time. And depending on the nature of the mutation, if that mutation doesn't offer an advantage to the virus, then it's either undetected or it dies out or it's replaced by a strain which is more hardy. So mutation is a normal occurrence and it occurs quite frequently. And it's not a question of months or years, although one would argue that the more people that become infected and the longer that you're infected, that the greater the risk that some type of mutant will arise that may offer some advantage to the virus. So mutation is a very common event.
But yet it seems like with the Omicron, what we ended up having was a higher contagion, but yet a less severe. And that typically denotes that it is exacerbating itself, right? Because it does not, it's not as strong as it once was. Would you make that a deduction as well?
Well, there's another feature about Omicron that we have to consider, and that is that there was a report or reports indicating that Omicron may have picked up part of nucleic acid from a seasonal coronavirus, which is a virus that causes milder disease. And as part of its genetic makeup, it may have it did acquire the ability to be more contagious, but because it has some of these other features from another virus, less severe. And so I think it's a combination of both of those things. And that can happen when two viruses co-infect the same host. And that's how we get new strains of influenza that arise, as we get, two viruses that infect the same host and they rearrange themselves and we get a new variant that arises. So I think that's the explanation for Omicron.
James, thanks so much for calling. I got a ton of calls piling up and emails I want to get to as well. So let's move along to Velda in Prince Albert. Hi, Velda.
Good afternoon. I'm certainly happy to talk to Blondeau today. I always miss his calls. However, one question that I would like to ask you, and my observation from my house window, I see that there's some people with, men, of course, with heavier beards. Now, we've been taught that the masks have to fit tight to your face, understandably, but how do they do that when people have a great big bushy beard?
Perhaps I should answer this question, Doctor?
It is a concern because it is true that if you do have a beard and if you have a lot of facial hair, then the masks do not fit, and if they do not fit snugly, then there is an increased risk in those individuals of acquiring the virus. That is just a mechanical function. If it doesn't fit snugly on your face, then any gaps that remain are potential portals of entry for the virus. So short of shaving, that is a risk that is coexisting in people that have a lot of facial hair.
Okay, the other thing that I've observed as well, that I see people on the street and so forth who have masks, just the blue lightweight ones, and my goodness, I think they've worn them for 2 years. They're so dirty, I can't believe it. I wouldn't want anything on my face that dirty. But they sit under their chin, or they have their nose sticking out, or whatever the case is. But I tell you, that's even more reason for me not to go into stores or public places. I am a bit of a hermit. I'm really not afraid of the virus because I'm very careful, but I will not go around people because they scare me.
Well, you do raise a good point, and I'll just comment on it quickly, in that the mask is only as good as the way it is worn. And if a mask has been worn, ad nauseam without being replaced, then the integrity of the components of the mask deteriorate, and to a point where it becomes less and less useful. So clearly, it is important to change masks on a regular basis, and it is important to wear them properly.
Well, Valda, as someone with a beard, I appreciate your concern for our safety. And yes, I've been going with a tighter mask as a result because it does fit a lot better, that's for sure. Let's move along to an email now. Dr. Blondeau, it's a bit of a two-parter, so let's start with the first part. Roxanne says, I understand that I'm less likely to get as sick as an unvaccinated person if I get COVID, but am I actually less likely to be infected?
So prior to Omicron, I think the answer to that was yes. But within Omicron, we know that there are a number of cases and lots of them, because we have Canadian data that show that that even if you're vaccinated, you could become infected with this variant. The reasons for that, I don't know that we fully understand the pathophysiology of it. Is it immune escape, which has been proposed in some research articles, saying that this virus can evade some of the mucosal immunity or some of the systemic immunity and cause infection? But it is that more robust systemic immunity that protects you from more serious illness. So sadly, being immunized is not a guarantee that you won't become infected, but it certainly significantly reduces the likelihood that you'll be hospitalized or die.
Well, and here's another one that we used to talk about a lot more, and this idea of viral load, which I don't think we've talked about in quite some time. And Roxanne wanted to know, are vaccinated people once infected just as contagious as unvaccinated people?
Yeah, that I would have a hard time giving you a direct answer on, because I've not reviewed literature that answers that question. What I do know is that there was at least one report, and I think one of the callers challenged me on this, that actually suggested that the viral loads were lesser in people who were vaccinated than in unvaccinated individuals. But we do know the incubation time is shorter for Omicron. So it's 1 to 2 days versus 3 to 4 days, and we know it peaks and declines quicker than some of the previous variants. So at its peak, this is a hard concept to actually. You could have less virus and still be more contagious if you have a more contagious virus, right?
Right.
So, and with Omicron, it's a more contagious virus. So in this particular instance, having a lower viral load does not necessarily mean that you still won't spread the virus, just because the virus is that much more contagious. But certainly having more virus and being more contagious is almost a guarantee for spread. So it's not an easy yes-no answer, but we do know that viral load increases and decreases quicker with this particular variant.
Okay, great. And another quick email here from Gwen, who says, if fully vaccinated, including booster shot, tested positive on the rapid test, and you have minor cold symptoms, no fever, how long should you isolate?
Now, we've been telling people that you should be isolating for a minimum of 5 days, and then if you're still symptomatic, at least 48 hours after your symptoms resolve.
Great.
So that's in that 5 to 7 day range, and then if your symptoms continue to persist, then you probably should seek an opinion from someone.
Great. Thanks for that email, Gwen. Let's go back to the phone lines. Janet is in Regina. Hi, Janet.
Hi. My question, I apologize if it's already been asked because I didn't catch all the program, but I'm just wondering about how long booster shots last. My husband and I both had 2 doses of AstraZeneca in the spring, and then because of the Saskatchewan government's encouragement, we were able to get 2 mRNA doses in the fall. So our last booster shot I guess you could call it, was mid-September. How long, do we know how long boosters are effective?
That's still a little bit of a moving target, but it's a great question. We know that there's some recent data out saying at least 3 to 4 months. In your particular case, because you previously had AstraZeneca, the clock may have been reset to zero for you when you started with the mRNA vaccines. So I don't want to say this as a fact, but you just might want to check and see whether or not you are eligible for a booster shot now. I don't want to say that you are,
okay.
but I would check that, and if you are, I would encourage you to get it. But you've technically received 4 doses of the vaccine, despite the political issues around the AstraZeneca vaccine. It was a very, very good vaccine, and it provided good protective antibody. So you've essentially received 4 doses of the vaccine, although your clock may have been reset to zero when you started the mRNA. So I would just check that out. And if you're eligible, I would go. Okay.
Okay. Thank you very much.
And thank you, Jenna, for calling in. Appreciate it. Let's go to Swift Current. Maria's on the line. Hi, Maria.
Hey. I was just wondering, because I know I read this book about malaria. Well, technically it's about mosquitoes and the effect of malaria in war, but they talked about sickle cell disease being an adaptation that helped people become resistant to malaria. And I was just wondering what the chances are that, especially with repeated inoculations of this virus, that our body would come up with natural ways to become resistant, and then we might be creating another adaptation in our body over time that might have its own ramifications.
Yeah, so sickle cell is, I'm not an expert on sickle cell, but that is obviously a blood-related disease, and it's actually only in certain members of the population. One of the hallmarks of coronaviruses, of which COVID is one, is that immunity does not tend to last forever, which is why you can be reinfected with it, every first or second year. And that's the same for other viruses like rhinovirus, which causes common cold. The immunity tends not to last very long. It's not like measles or mumps where you get lifelong immunity. And so as a consequence, I think there is an expectation that our immunity will wane over time. And depending on what the perceived threat is of the ongoing spread of this particular virus will dictate whether or not further immunization campaigns are going to be needed. But I think it is an expectation that we will not develop lifelong immunity to these particular virus. We'll develop, protective immunity that will wane over time.
Yeah, but I mean, will our body create its own thing based on, because, we're evolutionary creatures, right? We adapt to our environment. So would this cause some kind of adaptation similar to sickle cell disease?
I can't see that, and the reason being is because the body is challenged every day with various threats, and it wards them off through a number of different responses. And in order to do that, it has to see something as being foreign. And so when you're infected with a virus, it recognizes these proteins as sort of not belonging in the body, and then it mounts a defense. So in the absence of us continuing to be challenged with this particular virus, that's unlikely to happen. And with the immunization campaign, it probably reduces it further. But I cannot sort of off the cuff think of a reason why our body would adapt in such a way that would give us lifelong immunity to this.
Thanks, Maria, for calling in. We got to move things along. And actually, Fran, Marilyn, stand by. I'll get to you shortly. But I want to go to another email from Tanis, who first says thanks very much, or thanks so much, Dr. Blondeau. And Tanis's question is, can you be reinfected with Omicron after being infected yourself? I've heard 3 months of immunity is common, but that people can be reinfected much sooner than that. What do you know about that, Doctor?
I don't have the data to answer that. Peter, I get to ask that question all the time here at work. I will get docs that'll phone me and say, what's the chance that I've got a patient, they've had Omicron, what's the chance they have Omicron again? I don't have those statistics to answer that question. I simply don't know. Yeah. Is it theoretically possible? Yes. Do I have data to show how often it occurs? I do not. And so sorry, I can't answer that.
Great. No, that's totally fine. And before we move on, I promised right at the top of the show that we talked about the new vaccine that Health Canada has approved. What can you tell us about Novavax, Doctor?
So Novavax is yet another iteration in the COVID-19 pandemic. This is a little bit different as we've learned from the previous vaccines, which were messenger RNA vaccines. There were others that used viral vectors as well, that being the AstraZeneca and the Johnson & Johnson. This is what's called a subunit vaccine, which means that it actually has protein, the spike protein from the virus, which is formulated in the vaccine. It's injected into a person, and so the person's actually injected with the protein as opposed to having the body make the protein. And oftentimes these subunit vaccines are small molecules, so it's attached to something called an adjuvant, and an adjuvant's a carrier molecule which makes it more visible to the immune system. And so what we know about this particular vaccine is that it's a subunit vaccine from spike proteins, and that it has been shown to be highly efficacious in clinical trials. Over 30,000 people have been investigated, and we do know that it does have activity against Omicron, but not as robust as some of the activity against some of the earlier variants. You have to keep in mind, and this is the challenge, is that vaccine was being developed at a time when a different variant was circulating in the world. And so now, what they're trying to do is continue to enroll patients and then to see how the vaccine is performing against any other variants that arose since the vaccine trial started. But overall, it looks like a good vaccine. It looks like it's good efficacy. It's a 2-dose regimen separated by 3 weeks. And a lot of it's going to be manufactured in Canada. And I think that what that tells us is that the Canadian government and hence all of the provincial governments have obviously been working on a strategy for continuing the immunization program going forward.
All right, let's go back to the phone lines. Fran is in White City. Hi, Fran.
Hi. The question I have I've had my vaccinations. I started them last summer and I finished, a couple of months ago. But I have a question to ask. I seem to, in my left nostril, that I seem to have some blood discharge in that, not in the right one. And I've noticed on TV they show these little sticks that they put up people's noses. And I don't know if they're looking to see if there's any, blood discharge there. This isn't, something I'm really disturbed about. But I wonder if I should be looking. It's only it's in my left nostril, not my right one. And so what I've been doing is trying to clean it up with a Q-tip and some soap on there. But is that something that I should be looking at? I have a doctor's appointment for something different coming up in a couple of weeks, so maybe I should do it. But it seems like the people in the drugstores, like in White City or Emerald Park, they've been really very good too. I have to say that for the most part, the things that have been done have worked well for me. I'm quite happy with them. I wish they wouldn't have dumped them recently. I would prefer they still be there, but I'm kind of worried about these little sticks that they put up your nose, and I've seen them do this on television.
Yeah, so, the easy answer here is that since you're going in to see your doc, have to have a look in your nose. There are reasons why you could have, a little bit of blood there. Maybe you have some lesion in there. It could have been an abrasion and could be slow to heal. Some people get bloody nose in the wintertime. I know I do when it gets really dry and tends only to affect one side of I don't seem to bleed out of both sides of my nose. If in fact you had a stick shoved up your nose and you had some bleeding afterwards, I would have expected that only would have lasted for a short period of time unless you're on blood thinners or something. But I think the easy answer for you is, since you're going into the doc, tell them to take the scope, have a quick look up there and see what's happening, and that'll be your best recourse. Other than that, I really can't answer it more.
Well, Fran, thanks very much for calling in, and best of luck with that. We hope everything goes well for you. Let's go to Marilyn in Tisdale. Hi, Marilyn. Tisdale. Hi, Marilyn. Go ahead.
Hi. First of all, thank you, Dr. Blondeau, for all the information that you've given us through this pandemic and continue to do so. I appreciate it very much. And I have one quick question. Thank you. I have one quick question. I'm interested in getting an N95 mask to wear in some situations, and have gone to the pharmacy here and find out that there are K95s. And I wondered if you could comment on any differences in the N95 and the K95. Thank you.
So, yeah, you're welcome. So my understanding is that the K95 are actually, so N95 is a patented product from 3M. The K95 is actually a product from China. Both of them are good products. But they just have a different designation because they come from two different manufacturing sources. So I have an N95 because I've been fitted for it here at the hospital, and I know which ones actually fit my face. But I wouldn't hesitate to wear a KN95 if that's what was available to me.
Okay. Now, as for fitting, they have sort of one size fits all. Is that appropriate? I don't know.
Yeah, so long as it fits snugly to your face, then it will do what it's supposed to do. If it doesn't fit snugly to your face, like if there's big gaps and whatnot, so coming back to beards again, N95s and the KN95s are actually difficult for people that have facial hair because it's hard to get that tight fit. But for somebody like yourself, it should fit reasonably snugly, and that's what you want.
Okay, but no difference really in the function or the filtering of a K95 compared to an N. Okay, thank you. You have answered my question. I appreciate.
You're most welcome.
And thank you, Marilyn. Appreciate it. Best of luck in Tisdale. Let's go to another email here, Dr. Blondeau. Arlette emails, my husband and I are seniors, 70 years old. We haven't had COVID. We are fully vaccinated with 3 shots. My kids' young children have had Omicron recently. How soon is it safe to visit in their homes again?
There's no absolute answer to this because, in some people symptoms persist a little longer, but they should be symptom free for at least 48 hours before you go in. So, I mean, if you, depending on your level of comfort, because there's no absolute answer to this question, certainly, from when they first tested positive or when they were first symptomatic, if you give it a good 10 to 14 days, then that should be a safe time period.
Great. Thanks very much for that, Dr. Blondeau. If you have any calls, folks, you can get a last-minute one in, 1-800-716-2221. Again, 1-800-716-2221. 2221. We'll try to get a last-minute call in if you call right now. I got an email here from Jack who says, thanks for a very informative program. As usual, my question is, how long should I wait for a booster shot? I was 4 days away from a booster appointment in early January when I fell ill and tested positive for COVID. I had serious symptoms for 16 days. I have been COVID clear for 2 weeks, but have a low energy level and shortness of breath. How long before I should get the booster shot?
Yeah, so, my understanding is that once your symptoms have resolved, it's safe to go ahead and get that. But what I would do is, if I was this individual, because you're now eligible for the booster, I would make it known to the folks at the whoever's giving you the vaccine about your history there. But clearly, you want to be feeling well when you go. Because there may be obviously some side effects from the vaccine. I know for me personally, with all 3 doses that I have had, I was tired, more tired than normal. I was feeling a little achy afterwards. So, I felt a little rough for 2 to 3 days. And so if you're already not feeling well and then you go get the vaccine, then it's not going to make you feel any better. So you certainly want to be feeling better. But my understanding is that, once you're symptom free, you're eligible for your booster dose.
All right. We got a caller now. David is in Saskatoon. Go ahead, David.
Hello. So I'd like you to compare two people getting a third booster dose, one 3 months after the previous dose and one 6 months after. Would they get the same amount of protection from it, and would it last as long?
Yeah, so they get the same amount of protection from it, because that's a booster. What it does is it boosts your immune response. The difference is that the person who got the booster dose sort of 6 months later, and if the other one was 3 months later, if there was a 3-month difference between when they actually got their doses, and the level of protection in the person that got the 3-month dose will wane sooner than the person that got 6 months. If I'm not making myself clear, let's just say you had Peter and I were there, and Peter was 3 months today and he got boosted, and I waited 3 more months before I got boosted, then Peter's immunity would wane by the time I actually got my booster dose. So, but technically we would both get the same benefit from the booster dose. And then how long? Thank you. How long protective immunity lasts is still being defined because Omicron is still so very, very new. But 3 to 4 months seems to be reasonable at this time. It'll probably be longer.
Thank you.
And thank you, David, for that call. Dr. Blondeau, only got about a minute. We're just about a week. We're a week away from no public health measures in Saskatchewan. Any thoughts for residents as we move forward?
Yeah, very, very quickly, if you're an individual that's more elderly, if you're an individual that's unvaccinated, if you're an individual that has underlying medical conditions that are significant, even with the restrictions being lifted, there would still be value in you continuing to practice some of these public health measures that we've had in place for the last 2 years, including, distancing and masking and continue with hand washing. And certainly if you're an unvaccinated individual, vaccines work, and I would encourage you to explore that pathway to prevent you from being hospitalized or dying from this particular virus.
Doctor, always a pleasure to talk to you. Let's hope next time we chat it's a lot warmer outside.
I hope so. We have to get Fiona to fix that.
That's right. Well, I'll get on her today. Don't worry about it. Thank you.
All right. Take care.
That's Dr. Joseph Blondeau, the head of microbiology at Saskatoon's Royal University Hospital. He also teaches about infectious diseases at the University of Saskatchewan. We're very grateful for his time, and very grateful to all of you who called, emailed, and watched us on the CBC Saskatchewan Facebook page. Tomorrow on Blue Sky, this is a fun one. It's Leftover Line. Not all your leftover calls and emails. We're talking about whether you have a tip or hack for making meals last longer. This is something I was raised on. Can't wait to talk about that tomorrow. Take care.